Introduction. Good morning, all of our staff and fellow. My name is Athip Kongklam from Siras Hospital with my advisor, Professor Pop. Today, I will be talking about common injury we have seen in our practice, the MCL injury in ACL rupture. I covered this topic in the upcoming slide. And the combined ACL and MCL injury is the most common type of multi-ligament injury, with 95% of grade 3 MCL injury occur alongside the ACL tear. And we might underestimate its incidence. From this retrospective MRI study show us that in the patient who we thought that has only ACL tear, 2 out of 3 of the patient also has an MCL complex injury, with the SMCL being the most common injured structure. And why medial structure are so important in the knee stability? From the classic biomechanic data show us that they have a load sharing mechanism. The MCL deficiency can cause a load to the ACL, and the combined injury of them can even cause more anterior tibial translation. And it results in the clinical data. From the primary ACL data show us that the patient with combined injury also have more likelihood of the failure of the operation. And in the revision ACL also, with the patient with medial knee instability, there is more 17 times more risk of the failure. Before we can treat this injury, we need to understand how they happen. Take a quick look of this video. In the isolated ACL tear, the injury usually happens in non-contact situation with twisting force to the knee. And in isolated MCL tear, it usually happens from the contact at the lateral side of the knee, which causes the valgus force. And in combined injury, the force is more complex, with valgus force and also rotational forces. The associated injury was known as the unhappy triad, which is the combination of ACL, MCL, and medial meniscus injury. But Dr. Shelburne changed our ideas with his retrospective study. He showed us that lateral meniscus tear also happen more common. The medial knee structure has been described by many descriptions, but the key stabilizers are superficial and deep MCL and POL. Superficial MCL attached from the medial epicondyle to proximal tibia with 2 attachments. It acts as a primary stabilizer of valgus and external and internal rotation force. This MCL consists of meniscofemoral and meniscotibial ligament, and it acts as a secondary stabilizer of the valgus and external rotation force. Posterior oblique ligament or POL attached from distal femur and have 3 fascial attachments to the semibraminosus tendon. It acts as a primary stabilizer of the internal rotation. We can diagnose this injury by taking history, clinical exam, and imaging. Mechanism of injury and the activity that the patient has involved in can give us a clue of this combined injury. The high energy mechanism from contact sport or extreme sport, such as dirt biking, can give us a clue. And also the symptom, chronicity, and their demand and profile can guide us through the treatment. After the basic knee exam, we need the laxity testing. The first test is the valgus stress. It has been described by Feto and Marshall and grading by Houston, which measure the laxity as 30 degrees and measure the medial joint opening. Next is the test for the ACL, pivot shift test, Lashman test, and anterior dorsal test. But is it enough for this type of injuries? The biomechanic data from Dr. Wearer show us that the medial knee structure also provides anteromedial and external rotation stability, with the superficial MCL being the most important structure. So we might need another 2 tests for this stability. The first test is the classic test from Slocum since 1968. It can help us diagnose deep MCL injury. It can be done by placing the patient with 90-degree knee flexion, external rotate the tibia 15 degrees, and doing the anterior tibial translation. The next test is external diol test, which is not only the test for PCL and PCLC injury, but also medial knee injury. It can be positive at 30 and 90 degrees for the diagnosis. And here also propose the anteromedial grading system, which the severity is according to the injury pattern. Start with grade 1, with deep MCL injury, with anteromedial and external diol test. And higher grade of instability is always involved in a valgus stress test. We can send the patient for film of the knee, but most of the finding is no finding at all. But we can see the MCL avulsion, the chronic MCL insufficiency, which show a calcification at femoral attachment, which is known as perikinesia lesion. And also, we might see a cross joint widening. But in chronic MCL deficiency, we might need to evaluate the lower limb alignment by sending the patient for standing hip knee ankle film. The next important imaging is valgus stress test radiograph. It is an objective evaluation of the knee laxity. From paper from Laplace show us that grade 3 MCL lesion can be diagnosed by more than 3.2 millimeter side-to-side difference. MRI is a modality of choice and with high accuracy. It can be useful in acute case and help us grading a localized lesion such as the MCL entrapment. So these are treatment options for today's topics, but there is still no consensus for the optimal treatment. For the first two choices consist of conservative treatment of the ACL and conservative treatment of MCL or surgical treatment of MCL. The data from the past show us that most of the patient has instability symptoms and half of the high demand patient needs ACL reconstruction. And both of the choice has a very low return to sport rate. So it might be more suitable for the patient who has no symptom, don't want a surgery or contraindicated to the surgery. So that leaves us with the last three choices, which consists of the ACL reconstruction and conservative treatment of MCL and operative treatment of MCL. And we all know that MCL has a healing potential, but we have to know that which type of MCL injury will not heal. The first one is the MCL entrapment lesion, such as the sternal type lesion, which is the tibial avulsion of the SMCL and interposed over the pes anserinus, which prevent anatomic healing, and we need MRI to diagnose this condition. The other location that MCL can be entrapped is the intra-articular entrapment. On the right side is the group of patients that we question for the high demand patient that MCL might not heal or heal a little slower. From the data show us that avulsion injury, the ligament might took a little bit longer to heal when injured the near attachment site. And mid-substance injury tendon might be attenuated and have a poor quality. And data from 3-arm randomized control trial show us that there is more joint opening in the repair, in non-repair group compared to the repair MCL group. Conservative treatment is favored based on the result of literature in the 1980s, with higher rate of arthrofibrosis in the surgery group. But back then, many papers, they has no advanced imaging and have older surgical techniques. And nowadays, there is a topic that talk about the operative treatment of MCL with ACL reconstruction because we concerned about persistent instability. We have a modern method and implant. But is that true? So the systematic review that published last year show us that there is no difference between this intervention in terms of patient report outcome, activity, and range of motion. But there is a very limited data of the return to play. So no consensus yet. From the return to play data, there is evidence that in the patient with combined ACL and MCL who underwent conservative treatment of the MCL, they all have the same percentage of the return to sport. But the return to play in the combined injury is less. If we choose the conservative treatment, there are multiple regimens that has been reported. No evidence support one over another. So after my review, I can conclude that most of the others recommend that we should give the patient the hinge knee bracing for 6 weeks with limited range of motion for 6 weeks with gradual return to flexion every 2 weeks. The weight bearing can be full weight bearing, partial weight bearing, and non-weight bearing. And in the valgus malalignment knee, we might give the patient partial weight bearing regimen. And we should start the physical therapy as soon as possible and evaluate the patient at the 6th week. So when to do ACL reconstruction, the researchers have supported the acute ACL reconstruction with good outcome with no graft failure and residual instability. But the delayed ACL reconstruction after 6 weeks, which is mostly that we have encountered, have also an advantage of it allow low-grade MCL to heal, and we can evaluate it later. If we should repair techniques, the indications are bony avulsion injury and MCL entrapment, and after the failed conservative treatment. The implant is according to the location of the tear, such as bony avulsion or mid-substance injury. It can be augmented by semi-membranosus tendon technique or internal bracing. And nowadays, there are many novel minimally invasive techniques, but need a longer term of study. If we should reconstruction of the MCL, it should be preserved in the chronic injury with failed conservative treatment. The classic techniques are from Laplace and Lin, which involve SMCL and POL reconstruction. There are multiple graft choices, which is influenced by ACL graft choice in our operation. And there are many novel techniques, but there is no ideal technique because of the reason shown on the screen. The post-op rehabilitation for the surgery of the MCL in combined ACL injury follow the conservative treatment regimen with the number of 6 weeks. And we place the patient in partial weight bearing for 6 weeks and start the physical therapy as soon as possible as well. There is a role of biologic augmentation, but there is only one paper that reports the technical note. So we need to follow this trend along. So which is the best algorithm? There are many algorithms that has been proposed for the past few years, such as from Dr. Blanquet from 2017. He focused on the AMRI concept and placed all the patient on conservative treatment for 6 weeks, and then he evaluated with Slocum test. And if the patient has the MCL injury grade 3 or AMRI positive in grade 2 MCL tear, he will do the operative treatment. But in German consensus, they conclude that the operative treatment should be done in MCL grade 3 regarding of the location of the injuries. And from the last year systematic review from AJSM show us that they usually send the patient for conservative treatment with bracing and then evaluate with valgus stress and also stress radiograph. But they have an algorithm that in avulsion injury, we might consider an MCL repair. And in mid-substance injury, there is an option of the MCL reconstruction. So what is your choice? So let's wrap this lecture up with these key messages. Please don't miss combined injury after this lecture. And mechanism of injury can give us a clue. And physical examination is a key. And don't forget my video of Slocum and external dial test. MCL can heal very good with proper non-operative treatment with bracing, except for the MCL entrapment lesion. And in the avulsion injury and mid-substance injury is still debatable. And this factor that we have to be considered before we start the treatment, such as the location of the injury, the severity, the chronicity, patient factor, and their associated injury. Thank you.